Hi, doctors. Hope you're doing great. Welcome back to this discussion and welcome to the channel. We are today going to be doing a deep diving into the INI-CET November 2024 exam. So if you are planning to review your answers or learn a few concepts, the new ones, then you are at the right place. So give me a thumbs up with respect to whether the audio and the visual part is fine, and then we can get started. So I'll walk you through the examiner's thought process. I mean, what are they thinking? That's what I will try to tell you here. And this would help you analyze your preparation also better. I'll raise a couple of red flags also, a couple of green flags also for, so that you know what are your strengths and what are your weaknesses. And then you can fine tune your preparation strategy in such a fashion that in the forthcoming exams, you can excel even better. So grab a pen or a paper and make yourselves comfortable, and we can get started in like few seconds from now. The objective would be to come to the exact options, and subsequently we will be uploading the questions into the main section of the app. Fine, guys. So I think we are good to go with the very first question. Okay, yeah, I know medicine was tough. So let's focus on the first question for today. This was a 25-year-old female who's having palpitations and dizziness after playing lawn tennis. So traditionally, he always talks about football player and basketball player, but today it was lawn tennis. And then she is also having multiple episodes of dizziness and palpitations earlier also. And then a ECG was given where most guys were able to identify. Just zoom into the ECG. I think most people were able to identify the T wave inversion that was present in lead number V1. I mean, in the precordial leads, you can see a very symmetrical T wave inversion, which tells you that there is a problem with the heart of this patient. Now, before I focus on what is the core feature, like I'll just analyze the four options. And if like one of the very common things that they ask in the exam is hypertrophic cardiomyopathy, but hypertrophic cardiomyopathy should be beginning with episodes of chest pain. There should be angina episodes in a patient, and then subsequently there is description of syncopal episodes. So I was a little very skeptical when I listened to hypertrophic cardiomyopathy initially as an answer, which was like because the question will begin with chest pain, angina, syncopal, and then should be having presence of deep Q waves. Obviously, there can be T wave inversion present, but then there should be deep Q waves present. Unlike hypertrophic cardiomyopathy, when we look at arrhythmogenic right ventricular dysplasia, it will be predisposing a person more towards the palpitations part and the dizziness part, because anyway the name itself is arrhythmogenic. So I was very tempted to look at like whether we are having presence of epsilon wave, and yeah, at the terminal part of the S we are able to see that configuration. I'll try to draw that before you. Like, what I'm saying is at the terminal part of the S, what is present is epsilon wave, which helps in coming to the final diagnosis of this patient. But let's rule out the other option also, that is Brugada. I mean, Brugada, I think everybody could rule out because there would be an ST elevation with a cove pattern, which was not present in any of the leads. And most of the time, like the manifestations of cove pattern are like very characteristic. Sometimes they can be saddleback pattern also. So like there was no saddleback, there is no ST segment elevation. So I can rule out option number C. One of the aspect that was given was Uhel anomaly, which is like perfectly a new thing, suddenly a bolt from the blue kind of a question. So what do you mean by Uhel anomaly? Uhel anomaly means that the right ventricular myocardium is absent. And you're like, what? I mean, right ventricular myocardium is totally atrophied, or it is literally not present. So all that is present is right ventricular myocardium and right ventricular epicardium. The presentation of Uhl's anomaly is right ventricular failure, and it presents in children. So I can say that we should first think of like those conditions which are gonna present in adults as compared to that of pediatric age group. The age group of my patient is 25 years. So based on like the exclusion aspects is Brugada can be ruled out because there's no ST elevation present or co-pattern or saddleback. Hypertrophic cardiomyopathy begins with chest pain, angina, syncope, positive family history, none of that, and deep Q waves. I mean, I am not able to pick up Q waves there. I can pick up that slurred S wave followed by the slurring that is present of epsilon wave. So the correct answer for this one is option number B. And then Uhl's anomaly, I said, was like, very rare thing. So avoid answering ultra rare things in the exam. And that's a new thing that you need to remember. Uhl's would be RV myocardium totally absent. It's like an upgraded version of ARVD. In ARVD, there is a fibro-fatty deposition in the right ventricle, right? There is fibrosis and fatty material in the right ventricle. But here the myocardium itself is absent. So it's going to cause severe RVF in pediatric age group as well. So, Doc, Neeraj, you can listen to the Hindi version, and I think you would be able to get majority of the data there in case you want. Otherwise, the data is based on 21st edition of Harrison only. So that is my take on this. Unless they change that in Harrison, there is no point of changing the data. Okay, so we are sorted for question number 1. Can you comment in the chat box with respect to if there is any aberration in the choices? If not, we are good to go for the second question. Okay. Okay, good, Paras. I would suggest you to do main videos because the date has not been declared. So, I mean, why the casualness? My suggestion would be do the main videos and then subsequently go for rapid revision instead of trying to focus on just shortcuts. I think the hard way is always the best way. So thanks, Saurabh, for the confirmation. The options are perfect, and like ARVD is the main point to be expected because the question began with features of palpitations and no chest pain that would be present. Okay, so we are sorted for this one. Let's move on to the second question, and this one with respect to CPR and ROSC, that is return or spontaneous circulation. So closely worded options, TTM is targeted temperature management. What I can say is how to solve this question. You are aware of a concept which is called as therapeutic hypothermia, which is always going to be cerebroprotective. I mean, the main advantage of therapeutic hypothermia is that it is cerebroprotective. It will reduce the metabolism of the brain and will help the neurons tide over the crisis. It is done in those patients who would become unconscious and will become unresponsive. A couple of options look okay. I mean, mean arterial pressure of more than 65 millimeter of mercury is what I want to attain in a patient. SpO2 90 to 98 also looks very decent. So I'm left between two aspects. Let me just explain this to you or break this down before you. This patient would have probably had a ST elevation myocardial infarction. After that, he went into ventricular fibrillation. So he was in ventricular fibrillation for a period of time. And that is when you delivered a DC shock to this patient. And after delivering a DC shock, like you delivered a DC shock, so you'll see like a line or like an artifact in the recording. And then subsequently, you are once again noticing that the heart of this patient is restarting once again, though there might be like, bradycardia, but then normal sinus rhythm has been reestablished in this particular case. So the person was in ventricular fibrillation for a short duration. Then there is ROSC, that is return of spontaneous circulation. So you have to treat this guy by percutaneous coronary intervention. So emergency cardiac intervention should also be done. But targeted temperature management is to be done in those cases who have gone into a coma or who are like unresponsive. Therapeutic hypothermia is neuroprotective. Who are the patients who would be requiring therapeutic hypothermia? Are those who are having damage to their brain, because if the ventricular fibrillation will be very prolonged, usually going beyond more than 4 minutes, then you can understand that the person's brainstem would be affected. So even if after 4 minutes you get a return of spontaneous circulation, what you will be doing is in case the person, because there's a brain damage present, so you need to prevent the further worsening of the brain damage, and therefore you have to give targeted temperature management. The point against option number A is, I mean, why this is the answer to this question and why this is a not correct statement is that in this particular case, targeted temperature management is to be given to those patients who are unresponsive. I'll show you the reference also. I mean, the reference is that TTM, targeted temperature management, is to be done for comatose patients and not to be done for those patients who are awake. You can see that in option A it is written TTM to be given if the patient is awake, which is a wrong statement. It is targeted temperature management to be done in comatose patient. The logic is that you want to prevent the damage to the brain of the patient. Already there is damage to the brain, but you want to prevent the worsening of the damage to the brain. That is why therapeutic hypothermia is going to be helpful for the patient. So correct answer for the second question on the slide is option number A. And you can give me a confirmation with respect to if you want to modify the options here. Tags for custom module for INI-CET is deep diving. आप देखो ना INI-CET पे तो वो Uhls anomaly पूछ रहा है. नीट पीजी में तो Uhls anomaly नहीं पूछता. है ना, उसमें तो बेसिक लाइफ सपोर्ट और एडवांस कार्डियक लाइफ सपोर्ट के एस्पेक्ट पूछता है, इसमें वो पोस्ट रिकवरी पूछ रहा है। तो वन इज लाइक आई सेड इन द बिगनिंग डीप डाइविंग, और एक है लॉन्ग डिस्टेंस स्विमिंग। सो नीट पीजी एंड इनिसेट आर लाइक टू डिफरेंट बॉल गेम्स। सो फर्स्ट नीट पीजी में रैंक सिक्योर कर लो, एंड देन सब्सिक्वेंटली लाइक क्रैकिंग इनिसेट इज लाइक मच मोर अटेनेबल. I mean, obviously, people are able to clear INI-CET directly also, but then that would be like, I'm talking about average hardworking people. They first clear NEET and then they're able to get into the INI-CET in the patient also. Okay, so there is a non-ST elevation MI in the patient. Doc, I'll just note that down there. If it is like, so then there would be a little bit of difference in the aspect. Then option A will be that the patient is comatose. Like, then the difference would be because emergent cardiac intervention is to be done for ST elevation MI. That is percutaneous coronary intervention. For non-ST elevation MI, it's the medical treatment that you do. So like I get your point, and like the modified version of this question can be that in option number A, it will be written TTM for a comatose patient. And if it is TTM for comatose patient, then A becomes correct. And then A, B, C are the interventions that should be done, and the wrong statement will turn out to be option number D. But the gist of the question is what I have currently explained to you, that where would you do targeted temperature management? Comatose patient, person who's having brain damage. If the person has regained consciousness, then the incidence of brain damage would be relatively lesser. Or the incidence of like the possibility of this guy surviving will also be relatively more. That is the basic gist of this question. Okay. Good evening, guys. Fine. We move on to the next one. He said, which of the following is not a cause of high anion gap metabolic acidosis? Yeah. If it is comatose patient, that is okay, doc. If we change option number A to that of a comatose patient, then it doesn't make. Then it becomes option number D with respect to non-ST elevation MI. So, both versions of the questions would be valid, and the answers therefore can be worked out. Okay. Moving to the third one, which of the following is not a cause of HAGMA, that is high in N-gap metabolic acidosis? So that is a favorite of our examiner, that is Cult versus Dr. Fuse. And you can pick up all the options there: acute kidney injury, ketoacidosis, toxins, and diarrhea would always be a situation of normal and N-gap. That is Dr. Fuse, diarrhea, renal tubular acidosis, fistula, ureterosigmoidostomy are the situations here which has been evaluated. Okay. Good one. Inborn errors of metabolism. Amresh, that's a good one. Inborn errors of metabolism. Fine, I'll just put it there because, yep, there are a lot of inborn errors of metabolism that can be having metabolic acidosis as well. Too. So, good option there. Instead of toxins, that was the option that I was looking for. So multiple organic acidureas, for example, like you could be having inborn error of metabolism. They could be like disorders that we study in biochemistry, where metabolic acidosis can be the reason for development of encephalopathy in a patient. So metabolic encephalopathy. Fine, doc. Like I get your point. Like instead of toxins, what is present in this option number D is inborn error of metabolism. That helps us refine the language of the question. The answer remains uniform. Good. We move to the fourth one, which has been debated, TTP, thrombotic thrombocytopenic purpura. How I explain this is that Brahma, Vishnu, Mahesh thing, that Shivji is like a destroyer, and like Shivji is Adam TS13. And if Adam TS13 is defective, or if it is not there, then von Willebrand factor the multimers of that would result in formation of microthrombi, and they are going to cause consumptive coagulopathy, and that will cause thrombocytopenia in the patient. We get like the mnemonic that I've discussed is fat NRI for this, where in fat NRI I've described there would be fever, then there would be like, thrombocytopenia, abdominal pain, neurological manifestations. What you do not get in this patient, we do get renal failure in these patients, but what we will not get in these patients is going to be thrombosis in the large vessels. The correct answer for this one is option number A. I can explain like this, na, जैसे DIC में bleeding होता है, so consumption of platelets will occur and it causes bleeding. But DIC में भी तो microthrombi बनते हैं ना, वैसे ही this particular condition, TTP is characterized by deficiency of Adam 13, which is gonna be decreased or it is gonna be absent. So therefore, what will happen is that जो von Willebrand factor होता है, उसके जो multimers होते हैं, they get into action, and von Willebrand is like a tissue glue, so it will result in development of platelet microthrombi, and therefore what is going to happen is that the platelets will be consumed. The end result would be that these mesh of microthrombi will also impact the RBCs, क्योंकि RBCs इसके अंदर से जब निकल के जाते हैं So there would be scarring of the surface of the RBCs also. So that is why the term is MAHA, that is microangiopathic hemolytic anemia, and you can get a schistocytes present in this condition, or Burr cells that are present. So the main message is platelet microthrombi, so platelets are consumed, and then there is microangiopathic hemolytic anemia as well. And this process, the microthrombi, affect predominantly renal vasculature and the brain vasculature, because the microthrombi will predominantly be affecting the brain as well as the kidney microvasculature. That is why you could be having renal failure and even features of stroke in the patient, but it would not be a large vessel stroke. It would be like a small vessel stroke, and mainly ultra small blood vessels of the brain would be involved. But we do not have thrombosis of large vessels in thrombotic thrombocytopenic purpura. The term itself is a misnomer, and if you can go through this fat NRI mnemonic, then it would become relatively easier for you in the main section. Answer to question number 4 is option number A. In case of any aberrations in the options, do let me know. Otherwise, I think we are good to go as far as this particular question is concerned. Okay. Yeah, okay. I'll remove the word thrombosis in the large vessels. Okay, that is okay, doc. Even if I say thrombosis, no. So it is not like thrombosis as a manifestation is not seen because platelets are consumed in this condition. That would be the rationale. It's same as like in DIC, no? That DIC we have like clots also, and we have bleeding also, but then the main presentation is that of bleeding. Then is correct about resuscitation of children where adrenaline is going to be used. The only problem is with the dilution part, so I can rule out option number A here. And then we have discussed that in two rescuers, the ratio that would be used is 15:2. It would not be 13:2. For single rescuer is 30:2. For two is 15:2. Adrenaline is obviously given intravenously. So I think this was like even discussed by other faculties as well. The answer to this would be option number D. Initially, I thought it is adrenaline to be given intravenously, but then this is the feedback I got, intraosseous. So in case it was not present, then between C and D, I would have been in a fix. I mean, which of the two should be selected? But the correct answer for this, the way the question has been framed, would be given as option number D. Any modifications in the question? That would be great. ROSC is return of spontaneous circulation for, I would suggest you to listen to advanced cardiac life support. The last few minutes of it, ROSC is return of spontaneous circulation. The chart is from ACLS 2020 guidelines. And somebody was commenting that, sir, आप वो video update कर दो sir. ACLS guidelines come every 5 years. So next ACLS guidelines would be available in 2025. Till that, you have to listen to ACLS 2020 guidelines only. So please check out ACLS video and the ACLS update video also in emergency medicine, and that would help you in managing the patient. Yes, or we use intraosseous. No, we can use that Jamshedi's needle, and we can give intraosseous to the patient. We have that Jamshedi's needle na, for bone marrow biopsy. So we can use that Jamshedi's needle and give intraosseous also. Intraosseous is used in children for giving IV fluids also. Na? Like in some summer season, if you're working in casualty, you'll notice a lot of kids brought in shock and we are not able to get IV lines. So we give fluids also in those particular patients. I mean, IV fluids are given intraosseously with help of Jamshedi's needle. So giving adrenaline would not be a problem because the drilling action of the needle would help you get into the bone marrow of the patient. Okay, and bone marrow is very, very good related to bone marrow is having very good connection with the venous system. Somebody commented regarding adenosine. Okay, good. So I'll just jot it down, the adenosine part. Doctor, there is no role of adenosine. Na? There is a role of adrenaline only. There is no role of adenosine for management of this, but point well taken. I mean, that anyway negates option number C there. I'll just show you the chart once again, that advanced cardiac life support thing that I'm talking about. So check out the updates, updated, like the last video in emergency medicine, the ACLS update, and also the terminal part of ACLS where the recovery part has been mentioned. That is where therapeutic hypothermia has been discussed. Therapeutic hypothermia is both cardioprotective as well as neuroprotective. Okay. Moving to the next one, which of the following is not a feature of autoimmune polyendocrine system? So autoimmune polyendocrine system, like type 1 diabetes, we know this is going to be like autoimmune disorder. And most of the time, this autoimmune polyendocrine system can be associated with, please explain option C. Avinash, for which question? I think adrenaline is not given in is preferred to be given intravenously, no? in any patient of cardiac arrest, adrenaline is always to be given in a intravenous format. If you're talking about this question, can you mention the name of the question that we're talking about, or the number of the question we're talking about? Okay. Okay. Yes, Sonu, you can comment on the issues or the problem that you're facing. Whatever I can, I'll try to assist you. Okay. 5C. Okay. एड्रेलिन इज गिवन इंट्रावेनसली ना डॉक्टर, वे इंट्राऑशियस में तो टाइम लगेगा ना यार, तो मतलब इंट्राऑशियस में पहले नीडल मंगवाओगे, फिर एक्सेस लोगे, और मान लो एक्सेस नहीं हुआ, बोन फ्रैक्चर हो गया, तो दैट वुड नॉट बी अ वेरी वेरी प्लेजेंट सिचुएशन, नो, इंसर्टिंग अ नीडल इनटू द I mean, if you have tried doing it once ever in the casualty, you will realize it's not an easy thing to do. So that is why we will, and adenosine is anyway not used in resuscitation, no, it is amiodarone that is used. So 2 points. Okay, why C in 6? Type 1 diabetes autoimmune होता है ना बच्चे. In autoimmune polyendocrine system, there is gonna be autoimmunity which causes destruction of the beta cells, which would help you. Yes, doctor, we don't give intraosseous adenosine. We give intraosseous adrenaline to the patient. We don't give intraosseous adenosine to the patient. That is why I've ruled out option number C, Dr. Chandrasekhar. Okay, moving to option number C that talks about type 1 diabetes mellitus, because it is autoimmune, and because it is an autoimmune disorder, so additional thing or additional problem that can be happening in this patient is also a thymic hyperplasia. The thymus of this patient can also be affected. I mean, thymic hyperplasia can be a problem, and because of this thymic damage, in fact. So because the thymus of the patient can be damaged, that is why the immunity part in these patients can be reduced. So onset in infancy. And along with that, there is mention of mucocutaneous candidiasis as well, which is an association. The point is between option number A and option number D, what you have to understand is that hypoparathyroidism is also an autoimmune disorder. In fact, the main statement that I've given for hypoparathyroidism is that hypoparathyroidism is an autoimmune disorder, and the leading cause of that is not thyroid surgery, it is autoimmunity. And here it is written hyperparathyroidism, which is why the answer to this question is option number D. Between option number A and D, I've selected D for this one. Okay. Tejas, I've removed the word thrombosis in large vessels. Even if it is thrombosis, no, then we do not have thrombosis as the manifestation of thrombotic. The name is a misnomer. The name is thrombotic thrombocytopenic purpura. Okay. The question is, which of the following is not a feature of autoimmune polyendocrine system? What you get in this condition is hypoparathyroidism. I mean, if you listen to the discussion, no, there are 3 endocrine disorders that I have spoken, that is diabetes mellitus, Addison disease, and hypoparathyroidism. The logic to be only used is autoimmune word, and from that you can solve it. Hyperparathyroidism is due to parathyroid adenoma, na? It would be hyperparathyroidism of the primary variety is parathyroid adenoma. Hyperparathyroidism of the secondary variety would be like chronic kidney disease in a patient. So that is why the answer to this particular question would be option number D. Okay, we move to the 7th question for today. He says, which of the following statements about Behçet's disease is gonna be incorrect? And the pathology test is used for diagnosis. They would be after 24 to 48 hours, there would be a formation of a nodule at the site. So it makes sense. And then interstitial manifestations can manifest those of Crohn's disease, because Crohn's disease also begins with aphthous ulceration. And even Behçet's disease also presents with aphthous ulceration. So that makes sense. I mean, the manifestations can be resembling those of Crohn's disease. And then is oral and genital ulcers on the dorsal aspect of the penis. Well, you get ulcers on the genitals, but in a female, they are on the vulva, and in the male, the ulcers are present on the scrotum, and they're not present on the genitalia of the patient. If I read about D, then Behçet's disease is also in vasculitis, because Behçet's disease is also in vasculitis. So because it is a vasculitis, that is why the increased chances of thrombosis can be seen in these patients. So vasculitis, thrombosis makes sense, and the correct answer for this one would be option number C. For question number 6, doctor, you mentioned regarding okay, Amresh, can you help me out with the option for like you can see autoimmune polyendocrine system also, no? So if you can just look out if any other options was given in the question. APS1 presents with Addison disease, hypoparathyroidism, hypogonadism, Graves and diabetes. जो भी ऑटोइम्यून वाले सारी बीमारियां ना वो एक ही पेशेंट में आ रहे हैं और बचपन से उसको डायबिटीज ऑनवर्ड्स के बाद में ही मैनिफेस्टेशन शुरू हो जाते हैं. Like multiple endocrine neoplasia, he'll be having endocrine tumors. In APS, he will be having the endocrine disorders developing one after the other. The logic to be used is only कि कौन कौन से autoimmune disorder होते हैं. Addison, hypoparathyroidism, hypogonadism, और फिर Graves and type 1 diabetes. Any eye manifestation, I would be glad if you can assist me with that for the sixth question. Okay, waiting for any input for question number 6, option number D. Okay, hypothyroidism. Okay, fine. So that also helps me in giving the interpretation, no? Because it would be Graves' disease that would be present. It is Graves' disease that would be present. I'm just putting that in place of option number D if hypothyroidism is there. So remaining things will fit the bill. I mean, thymus is involved, so you can be having mucocutaneous candidiasis, infant presentation, type 1 diabetes. That helps us, exclude the options, right? I mean, A, B, and C are the ones which are seen. So D, if you're saying hypothyroidism, that fits the bill because what you get is Graves' disease in this patient. Okay, thanks Chandan for the input there. Moving to the next question, he said patient presents with history of oral and genital ulcers are present, Aman. Yes, that is the trick in the question now, that the ulcers, check out the video, the ulcers are not present on the dorsum of the penis, the ulcers are present on the scrotum of the patient. We get oral and genital ulcers, but the trick in the question is that line. That is why, reading that line is what I emphasize and is the one which is asked in INI-CET exam. That is why I said it is deep sea diving. That is ulcer on the dorsum aspect of the penis. That is the key word in the question. It is not on the dorsal aspect. It is the scrotal ulcer. So that is the reason, Aman, for this one. Okay, Aditya mentioned bilateral anterior uveitis. Fine. I'll take that into consideration. But if the options are same, the answer remains what I have currently described. Fine. We move to the next one. This is with respect to multiple peptic ulcers, which are located in the jejunum of the patient as well as in the duodenum. I mean, normally we get peptic ulcers in the first part of duodenum. So the first line itself is telling you that he's talking about Zollinger-Ellison syndrome because the key word is multiple peptic ulcer. Yeah, SS, taken your point. Hypothyroidism helps us in picking that up as an answer primarily because what you get is, I showed you the screenshot also. No, it's not that we are just bluffing on any data. You can see that the data that is given is what I have currently shown you. That would be Graves' disease usually present in this patient. Okay. Thyroiditis would mean damage to the gland, so that will result in hyper manifestations. When you have thyroiditis, it causes initially hyper manifestations in the patient. Okay, let's move on to the eighth one there. The first line, the question tells me that we are dealing with Zollinger-Ellison syndrome. Workup of the patient is a pH very low and fasting gastrin levels. So he's talking about gastrinoma triangle only, guys. I have hand drawn the diagram for the same also. So you can pick up that this would be between the confluence of the cystic duct and the common bile duct. Then is the neck and the body of pancreas in second and third part of the duodenum. I'm going to quickly draw this next 15 seconds, a quick look at that triangle that I'm talking about. That's going to be like the cystic duct uniting with the common bile duct. Inferiorly, I will be drawing the duodenum. That's the first part, the second part, and the third part. And then it's going to be the pancreas. That's going to be the head and the neck and the body. And then we are going to draw a line like this, confluence of these, and then hitting the neck and the body of pancreas, and then putting a line cutting the second and the third part of the duodenum. This is D2, and then we have D3 inferiorly. So if you join this, it becomes a gastrinoma triangle, and that's the site for Zollinger-Ellison. So that helps me with the answer to this question as option number A. More of, I would say, surgery / medicine based question. Yeah, this one's interesting one. I would like a very lot of, I would like you to hit the comment button for this one, especially with respect to the options. Young lady comes with complaints or difficulty in swallowing, skin tightening of fingers and fingertip discoloration. So there is a Raynaud's phenomenon present. And then he mentioned telangiectasia in the question also. And you could see this like, centromere pattern or spotted pattern present. So my question to you are, okay, confluence. Okay, got it, Ansuman. I mean, that confluence basically means junction. No, maybe that word or spelling would be wrong, but like the anatomical terms are like cystic artery and cystic duct. So I think it would be cystic duct and the common bile duct. Okay, fine. We move ahead for this one where we are talking about scleroderma versus CREST syndrome. So I would like to know from you whether telangiectasia, yeah. Whether telangiectasia was mentioned in the question or not, because this is a variant of scleroderma. So I think there were two options. Okay. Yes. So if telangiectasia is present, Ved Prakash, can you just frame one option for me, just one option for the previous one? And meanwhile, we are moving ahead. Okay. Okay. But in two options, one option was cystic duct and the other one was the common bile duct in the patient. So which one would be correct? Okay, doc. I would go by common bile duct, right? Because that is where the A point or the initial point of ours is starting. It's not exactly the starting of the cystic duct. It is where the cystic duct is ending and the CBD is starting. So it's the starting point of the CBD that we'll be taking into consideration. So Tejas, you have a point there, but in my opinion, it would be the starting point of the common bile duct. That would be point number A that we'll be taking as the reference point for making the Pissarro's triangle or the Gastrinoma triangle. Okay, so I get a confirmation that there were telangiectasias and the centromere pattern was present. Let me know even option number C, crest was written, or was it systemic sclerosis centromere pattern? In option number C of this question, was the crest word given, or was it scleroderma or systemic sclerosis, whatever, with centromere pattern? Okay, got it. I got it. Systemic sclerosis, and along with that, the centromere pattern would be given. So the correct answer for this one will turn out to be option number C. I got your point, doctor. And the centromere pattern is what is present here. CREST syndrome is centromeric and anti-centro. I mean, CREST syndrome no, begins with C. So the word that we have always talked about is anti-centromere antibody. So we just have to pick it up. I mean, even if we don't get the image right, CREST syndrome can be picked up by the antibodies as I have highlighted. Answer to this one would turn out to be option number C. The third one is correct. Then is vaccine that would not be required for a person who's old age. So we will give vaccine for hepatitis, for chickenpox. That's important. Chickenpox in old age can turn hemorrhagic as well. Influenza because the risk of viral pneumonia in these patients. But we would not be using human papilloma virus. Yes. Okay. The answer for this one would be human papilloma virus. Okay, so got it. Multiple options have to be selected. So A, B, and D. So the way we will frame the questions, it would be like multiple options in the question would be selected in those circumstances. Got it. Got it. Multiple options would be selected. Got it. Answer to question number 10 is option number C. Moving to the next one, you are drawing blood sample for serum calcium. Which of the following is to be avoided to prevent false or erroneous reporting of calcium values in the patient? Let's first settle the options and then we can move on to the correct answer in this question. One, I want to know, was it like false elevation, false lowering, or was it like a false reporting only? Okay, I'll just add that to the previous one, pneumococcal. Yes, sir. We will be giving pneumococcal vaccine old age also. That is to prevent the pneumonia component. The question of mine here is like, was it mentioned like false elevation, false lowering? Okay, false reporting is fine. So let's work it out. Sodium citrate will be causing false report, false low report, in fact. Then forearm exercise, because forearm exercise will cause lactic acidosis. I think it was either forearm or fist clenching, I don't know. But either of the two activities, like if we ask the patient to do like this, no, to make the veins, like we ask him to do like this, then forearm exercise and fist clenching will cause lactic acidosis to be present. And lactic acidosis is the trigger or the problem in this patient because it will cause calcium to dissociate from albumin. And the moment the calcium will be dissociating from albumin, then the problem will start. The problem would be that the calcium values will turn out to be higher. And then prolonged immobilization of the patient again is a risk factor because that causes osteoclastic activity and calcium to be elevated. So again, false elevation would be present. And when you are gonna cause, whenever you will take a calcium sample, the moment the blood will come in the hub, immediately you have to release the tourniquet, because if you put extended tourniquet for long duration, it causes venous stasis, and stasis again causes acidosis, and acidosis causes calcium to dissociate from albumin. So it is like the moment the blood will come in, the normally what happens is like we are drawing the sample, so usually the tourniquet is released a little late. In this case, what you will do is that the moment the blood will come in the hub, immediately you should be doing a rapid removal of the tourniquet. The reason is that if you put tourniquet for long duration, the logic or rationale is that if we will be putting prolonged tourniquet, then it will result in development of venous stasis, and the venous stasis component, the stasis word always means that there would be some kind of an acidosis component coming, and that is why calcium is very sensitive, because some of it is bound to albumin, some is in ionized format. So that shift happens, like that alkalosis causes tetany, and acidosis contributes to rather the ionized calcium values to become elevated. So I don't want any aberrations there. So what is gonna be avoided? So this is like avoid, because of the fact that values will be low. Exercise to be avoided. Why? Because of the acidosis component. Immobilization of the patient prolonged is a risk factor for causing hypercalcemia, but rapid tourniquet is a good practice that would be done. And that is why the correct answer for this one from the options that I have selected would be option number A, B, and C. If there is any variations in this question, let me know. I mean, we spent a lot of time working out the options for this one. Yeah, which one will be avoided? Yes, yes, yes. Which of the following is to be avoided? So A, B, and D. I think Tejas, both questions. I mean, the language would be using tourniquet in the option. Okay, okay. Yes, tourniquet is to be applied just before taking of the blood and remove it. Got it, Sakshi, got it. That is the same gist that I'm explaining to you, कि यहाँ पे उसको fast निकाल दो, rapid removal of the tourniquet. I mean, just before taking the sample. I got it. The language may be a little different, but I think I've given the concept to you, because I said that is what this session is about, all about. That just, I mean, obviously किसी भी sampling से पहले tourniquet लगाते हैं, right? The only point is कि उसको जल्दी release करना है, क्योंकि अगर tourniquet लगा रहेगा तो venous stasis की वजह से वो changes आ जाते हैं. So I think, Sakshi, I'll just take a snapshot of the language that you said. The wordings that you have said are the ones which you saw in the paper, and the gist of that is what I have said, that rapid removal of the tourniquet is the one which would be a good practice, and prolongation of the tourniquet is a bad practice. So thanks, Dr. Sakshi, for that input there. Okay. Can free calcium and total calcium both increase in both bone reabsorption? Yeah, doctor. It will increase now, because osteoclastic activity will osteoclastic is universally gonna increase. It's gonna destroy the bone, no? So both the ionized calcium and the total calcium in the patient will become elevated. The correct answer for this one will be option number A, B, and C. I mean, the point is good practice versus bad practice. So A, B, C are like, don't make the patient do like this. At the same time, avoid like immobilization patients. You need to be wary about the false elevation anyway. And citrate binds to calcium. That thing from your biochemistry aspect also. So we are sorted for this one. The answer is option number 2 for question number 11. And we move on to question number 12. JAK inhibitor used in severe ulcerative colitis. The movement, it is like JAK inhibitor. It's the era of JAK inhibitors nowadays, whether it is rheumatoid arthritis or whether it is going to be ulcerative colitis. The answer in this particular case would be given as tofacitinib. And the remaining molecules would be having little different actions like, Ozanimod would be S1P modulator. So this is gonna inhibit the immune system from attacking the GI tract, because inflammatory bowel diseases where the immune system starts attacking self only. So each one of them are having their separate actions. But then if you just follow the flow chart for severe and ulcerative colitis, one of the main molecules right up there is tofacitinib, and that is the one which has been mentioned here. For the next question, the query is whether this was GBS in child or whether this was GBS in adult. Dr. Sana Qureshi, I would not recommend that personally for using this session for FMG exam. I mean, please don't make your life more difficult. Okay. GBS was for children or was GBS for adult? That is one. And then we'll like just go through the options here. IVIG, cytological albumino dissociation. Well, you can call it albumino cytological dissociation as well. And then it's gonna be areflexia and plasmapheresis. The question is regarding which of the following is incorrect. Okay, child is mentioned. Okay, so that is one that some people had remarked child, some people said कि adult था. So it's okay. Like child में वो अमन होता ना ज़्यादा. In child, it is not AIDP, na? It is AMAN, that is acute motor axonal neuropathy, or AMAN is present. Okay. Plasmapheresis is not effective. Okay. Okay, fine. I'll mention it. I'll show you the reference also. I got the point there. In the first question, V1R is bigger than the S wave. Doc, that alone is not the criteria for right ventricular hypertrophy. Na? ECG is poor for analyzing or evaluating right ventricular hypertrophy. It's good for left ventricular hypertrophy, but not for RVH. The diagnostic criteria say that the accuracy of criteria for RVH are less than 50%. Okay, which of the following is incorrect about Guillain-Barré syndrome? So, okay, SR, I have a point. You know, I was anticipating that false elevation, right? My question is very simple. Would a doctor be interested only in false elevation? Would you not be interested in false lowering also? No? I mean, if you are taking a sample of a patient, it could be false elevation and false lowering also. So I get your point. If you want to modulate this question or the option, then it can change in a different way. I'll just go back to that. Like instead of rapid removal of tourniquet, I can make it prolonged usage of the tourniquet, and then B, C, and D would be causing elevation, and A will be causing less. So if you say that the framing is like less versus more, then the moment the wordings will change, the analysis will change. But I think most of us are coming to that false erroneous reporting of calcium. My point is like if I am interested in taking calcium of somebody, then I will not be interested only in false elevation. I'll be interested in false lowering also. So that is the first word that I underlined. That is it like okay, false erroneous reporting of calcium values, and that is why like the explanation has been made in this fashion. Okay. Moving to question number 13, intravenous immunoglobulin is the first line treatment. That is perfectly fine. And cytological immunological dissociation is seen in Guillain-Barré syndrome is okay. Areflexia is one of the diagnostic criteria for this patient. You see, I have highlighted this fact that intravenous immunoglobulins and plasmapheresis, both of them are first line treatment for GBS, and depending on the facility, either of the two can be used. I'll just show the reference for the same also from the book also. He says either of them, either intravenous immunoglobulin or plasmapheresis can be initiated as they're equally effective in typical Guillain-Barré syndrome. So the message is it is not that plasmapheresis is done in refractory cases or it is not effective in refractory cases. It is either of the two can be used. He's himself mentioning that IVIG is the offer initial therapy chosen because of ease of administration and good safety record. But then this statement is, I would say, the wrong statement here. Plasmapheresis is not done in medically refractory or it is not effective because it is one of the highly effective maneuvers. And second, like it is not that first we will give IVIG and then we will give plasmapheresis. It says any of the two based on the facility can be given to the patient. And it's not that plasmapheresis is for refractory variety. That is why the answer to this question will turn out to be option number D. And whether you say cytological, albuminological, or whether you say albuminocytological, both basically mean the same, that everything will be normal, cells, sugar, color of the CSF, but the only thing elevated in the report will be the protein value because only the proteins are elevated and everything else is normal. That is why you will call it a albuminocytological dissociation. So the correct answer for this particular question would be given as option number D. The next one, this is gonna be riot, but still let's do it. A 30-year-old patient presents with history of weight loss, mediastal lymphadenopathy, and pleural effusion. And HRCT shows a tree in a bud appearance with lung consolidation. My question here at the moment is the age group okay? Was it like a smoker? Was it like COPD patient, cystic fibrosis patient, immunocompromised patient, person on steroids? Anything given with respect to some risk factor in the patient? And meanwhile, I'm writing the differentials of this patient. I mean, tree in bud appearance has a huge amount of differentials. It could be TB, it could be pneumocystis jirovecii, it could be aspergillus. And those are the differentials that we need to consider. And then obviously connective tissue disorder, that could be sarcoidosis as well with respect to tree in a bud appearance. So before we get into the subsequent line of the question, I repeat my question is, was this question mentioning anything with respect to a person having some kind of concomitant immunocompromised state? Okay, there was no risk factors given in the patient. So basically my point is this is a immunocompetent patient. Immunocompetent would mean that the fungal hyphae thing would be a little less likely. And I said that is the reason why I know this will start a riot. Pleural fluid analysis reveals low adenosine deaminase levels. Yeah, one report say, can you rule out tuberculosis? I mean, everything else is going in favor of TB. What are the things in favor of tuberculosis? I'll just write it. First and foremost, like I can say the history is suggestive of tuberculosis. Lymph node enlargement is suggestive of TB. There is a pleural effusion hydrothorax which is present. There are 4 points in favor of TB, including the CT finding, tree in bud appearance, which is that of endobronchial TB. The only thing that is against tuberculosis in this particular case is the tree in bud appearance is endobronchial tuberculosis. There are 4 points in favor of tuberculosis, and only one thing is against tuberculosis, that is adenosine deaminase levels are low in the patient. So low levels never rule out a disease. Elevated will help in diagnosis of tuberculosis. He is asking you what is the most likely finding in this case. My thought process on this question is that you see, everybody can rule out anthracosis and everybody can rule out reactive hyperplasia. Between the two only we'll be fighting. Either it is going to be TB or it is not going to be tuberculosis in a immunocompetent patient. In a immunocompetent patient, can we have aspergillosis being present? I mean, if that is true, then I think it is the end of the human race. And with one report of adenosine being less, like can we rule out TB? Like I'll better do a pleural biopsy of the patient, not to be sure, because the best way for diagnosis of TB involving the pleura would be a pleural biopsy. Or we can do CB-NAT on the patient. So one low level, I don't think so, will help in ruling out the fungal hyphae part. And this I know would be, I would rate this as the most, I would say, plus minus or controversial question. I would like to answer this as tuberculosis because of the high incidence of TB in India. Like एक report ADA की कम है, उससे TB को rule out नहीं कर सकते यार in a scenario of a high endemic setting in a country. If it was like USA and or any other country, developing country where TB incidence is lesser, because he's also asking you what is the most likely feature in this particular case. So if immunocompetence is given here, aspergillus कब होता है, तो ABP है ना, you are saying कि it could be your point will be कि सर ये तो it can be allergic bronchopulmonary aspergilloma. So allergic bronchopulmonary aspergilloma is what is encountered in asthmatics, or they could be seen in cystic fibrosis. Yeah, cigarette smoker, yeah, somebody on steroids is where aspergillus would be a risk factor. He's saying what is the most likely finding on the biopsy of this patient. So yeah, I agree to the fact that if I focus only on this much, if I just say low ADA levels, then chalega. I mean, I'll say, okay, ji, fungal hyphae surrounded by lymphocytes in the patient would be the first answer. But then I need to ask myself, is it like possible? Like, what am I telling the patient? You are having aspergillus infection and you are immunocompetent, and still you are having like aspergillus infection. That is a little unlikely in a high endemicity in a country. So empirical ATT treatment would be started in this patient, even if the biopsy report is inconclusive. The answer to this question, in my opinion, would be given as option number B, that is necrotizing epithelioid granuloma, which is one of the characteristic feature that would be seen in this patient. Reactive lymph node, okay. Reactive lymph node hyperplasia. Okay, doc, that I have modified here. But I've given you reasons. The reasons are like there are 4 points in front of favor of TB and 1 point is against tuberculosis. Only low ADA level is one. The textbook says that high ADA is suggestive of tuberculosis, but he says that low does not rule out the possibility of TB. So we can be doing a pleural biopsy in this patient in case the lymph node report turns out to be inconclusive. The answer to this question should be given as option number B. Then is regarding celiac disease, we have TTG antibody, we have Marsh criteria from histology perspective. Anti-gliadin antibodies can be used for diagnosis, but then what is present here is HLA DQ2 and DA8. So this would be the answer to this question. This was much more simpler and straightforward. Which of the following statements is incorrect? And D is the answer to this one. Any modifications in the options, let me know. Yeah, Aman, it was a good leave actually, because it can go either ways, right? It was a very closely worded one. Okay, fine. We sorted for 15, we move to 16, that is EGFR grade 3B. So how to remember this is like just go 30 points less between 30, first write like 90, 60, and then 30. And then you have to decrease like by 15, 15. So when you decrease by 15 here, this would be like between 45 to 59, and then would be between 30 to 44. That's the value to be remembered. And because it's saying 3B in this case, so this would be 30 to 44. It's like decreased 90, 60, 30, then decreased by 15, 15 for 3A and 3B respectively. And you can work out the interpretation in this question. Coming to the 17th one, let me know whether vanillin mandelic acid was in the options or was it MIBG scan. And then I'll come to the answer to this question. Yes, guys. First investigation to be done for diagnosis of Pheochromocytoma. Was it vanillin mandelic acid in the options or was it MIBG scanning? If options are fine, I can go ahead with the answer for this question. Okay, fine. So first and foremost, I also want to bring to your attention because I had like some doctors saying and they were adamant that sir, VMA was given. VMA is useful for diagnosis of neuroblastoma. VMA is used for diagnosis of neuroblastoma. I have another option coming up, that is imaging in the form of MRI. Doctor, for any tumor, first we need to look for biochemical evidence. For if I say, saying to somebody that you are having a tumor and that tumor is producing some hormone, the first test to be done in the patient is always biochemical evidence. And once you have a biochemical evidence, then you do imaging in a person. It is not other way around. Like if I suspect pheochromocytoma, person was having symptoms of anxiety and he's not responding to anxiety medicines. Plus there is hypertension also, episodic hypertension, fluctuating blood pressure, paroxysmal hypertension. So we will do a urine test in the patient first. So in any patient of pheochromocytoma, like the word that I've said is screening test, or the initial test to be done is biochemical evidence. That would be urinary metanephrines to be done in this patient. And the table in Harrison says the same thing as well. That is, yeah, VMA is not given in the options. That is one. Some people said VMA, so I said unlikely. VMA is for neuroblastoma. And even if it was there, even then, like Harrison doesn't mention about it. Then what about MIBG scan? All imaging tests are to be done. First, we do biochemical evidence, and after biochemical evidence, then subsequently imaging of any patient is done. This is a standard protocol for any endocrine problem. No, like if I'm saying hyperthyroidism in a patient, I first will do blood test. And then I will do ultrasound of the neck to demonstrate, okay, there is an enlargement of the gland, there is a diffuse enlargement like in cases of Graves' disease. So the point to be understood is that imaging is always secondary to biochemical evidence, which is why the answer to this question would be given as option number B. That is urinary metanephrines is the initial screening test for this patient. Yeah, 24-hour. Okay, I'll write it. 24-hour urinary metanephrine values. Okay, metanephrine and VMA in a single question, I'm okay with it. If it is metanephrine and VMA in a single question, I'm okay with it. That still makes it the answer to the question because, as I said, the biochemical evidence is what we need to focus on. Great. So I think we are done with this one. The answer is beta. Imaging is always secondary. Then this criteria, I think this is a highly discussed question. True love and Witt's criteria for ulcerative colitis. There we talk about, how many loose stools per day, heart rate of a patient, respiratory rate, ESR of a patient. So we are trying to evaluate the severity of the disease in the patient for true love and Witt's criteria. The answer to 17 was B, 18 is option number A. Then which of the following is an acquired condition? So all of them, three of them, protein C, protein S, antithrombin 3, they are all hypercoagulable states. And then so is factor 5 laden mutation, where the binding with protein C is defective. But one problem that would be present in this case is PNH, that is paroxysmal nocturnal hemoglobinuria. PNH is like a condition which is an acquired one, PIGA gene and CD55 deficiency. So there's a complement mediated destruction, and that is why will turn out to be a answer to this question. All others are that are present are genetic questions. Encephalitis for which one, doctor? Okay, one option in this question was encephalitis. Got it. A little unlikely, doctor, but still a little unlikely, but still. Even homocystinuria, doctor, like even if I modify this, no, if I change it to homocystinuria, then you know that this is a autosomal recessive condition, very common. Homocystinemia and homocystinuria, both of them are like interrelated and they are genetically acquired conditions. But PNH is unacquired. Okay, moving to the next one. Which of the following is not a component of multiple endocrine neoplasia type 2B? 2B is like you read about like 3Ps, then you read about ppm, and then when you read about 2B or men3, then those M start coming now, that Marfanoid habitus and medullary thyroid cancer, mucosal neuromas. So the answer in this question will work out to be given as option number A. Okay, not an acquired cause of thrombosis. Okay, got it. Not an acquired cause. Can you tell me why are platelets causing clots in PNH? Anyway, the answer is sorted out. Can you tell me why platelets are gonna misbehave why do you get Budd-Chiari syndrome in PNH? Just a general question. If you can just comment in the chat box. Not an acquired cause of thrombosis. Okay. Yeah, doc got it. Not an acquired cause of thrombosis. That makes it okay. I mean, the answer still comes to the same conclusion. PNH is like CD59 is missing now. CD59 is what prevents the platelets from interacting. Here, the count of the platelets is normal. Like this disease is a problem with not the quantity but quality, because the quality of the platelets is defective and they start interacting with each other and start forming thrombosis. PNH as a disorder is where poor quality RBCs are being produced, poor quality platelets are being produced, because poor quality RBCs are getting produced, so they get destroyed by the complement system, and poor quality platelets are being produced, so they start causing aggregation, platelet aggregation. Normally, platelets are prevented from aggregation with each other with CD59, because CD59 is missing. So that is why I said like the platelets are of poor quality. So this is not about thrombocytosis, but it is about normal platelet count, and in spite of that, the thrombosis part can be seen in the patient. Complement activation, doctor, is more valid for that the anemia component that is seen in this patient. That the first morning urine sample will be black, and then the blackness will gradually reduce when he will drink water. But then the point is hemolysis is in this condition usually is more at night. So the first morning urine sample will be like black, and then the blackness will become relatively lesser. So I think we sorted for 19 and 20, and we move on to 21. Name criteria for Carney's complex. So we have they ask syndromes, no? Nevii, atrial myxoma, mixed tumors, and then E would be what is iphilides. Iphilides are basically other name for freckles. Like lot of time, Gora people you would have seen, they would be having lot of freckles on the face, no? Like if you see some white people, they would be having those brown spots on the skin. That is iphilides or freckles. That is the E component which is present there. But it was Epstein anomaly. Epstein is gonna be like tricuspid stenosis with tricuspid regurgitation, the TS and the tear component which is present, which is why it can be ruled out. Okay, then is a question for best imaging modality for a kidney stone in a patient. So kidney stones would be having most of the time calcium present. So we will be using a non-contrast CT that would help us in analyzing the presence of kidney stone. Ultrasound can be done, but then it can miss out a small stone. So that is why it is option number A that would be answered for this question. Yeah, hypoventilation at night is one of the postulates that is described, that the respiratory rate is little on the lower side, so acidosis activates the complement system. No, doctor. The best imaging modality is not ultrasound, because ultrasound can miss out small stones because of the gas in the abdomen. No, so lots of time, like especially stones, if they are present, so gas in the abdomen can contribute to possibility of the stone being missed. Then can be abdominal fat also, like somebody is having a pendulous abdomen. So abdominal fat can also be affecting the ultrasound interpretation. So a non-contrast CT would be the best way for diagnosis. Best investigation, doctor, means investigation of choice, not the gold standard. It means best investigation. If he says initial investigation, it is ultrasound only. I agree to that. But then best is CT scan, because you are not going to miss it. Gold standard is one which may be invasive also. तीन होता है ना, एक होता है स्क्रीनिंग टेस्ट, एक होता है इन्वेस्टिगेशन ऑफ चॉइस, एक होता है गोल्ड स्टैंडर्ड कैन बी इन्वेसिव टेस्ट ऑल्सो, लाइक फॉर coronary artery disease. I've said कि the gold standard is coronary angiography. Now you tell somebody I'm gonna puncture your radial artery and femoral artery, तो वो तो I mean he's gonna be like looking at you मुंह खोल के कि भाई क्या बोल रहे हो. तो मतलब most people would be agreeing for a CCTA. So that way, like invasive gold standard may not be practical, but investigation of choice has to be sensitive, specific as well as practical. Okay, okay. This would be contrast enhancement. No, no, sir, हम plain CT करते हैं ना. Contrast enhancement तो inflammatory conditions के लिए करेंगे ना. अगर कोई inflammatory condition होगी तो CECT करते हैं ना. Otherwise तो okay, got it. So यहाँ पे ureteric stone है तो it becomes even much more accurate. A CT scan, because if I do remove the word renal, no, ureteric stone will be chota, so even the chances of that being missed out on ultrasound would again be an issue. So bias can be with respect to size also. I mean, ultrasound abdomen, the size of the stone, if it is gonna be small, then it is likely to be missed. So that helps me make the diagnosis also. If you listen to kidney stones, so first thing I've said is this: imaging modality of choice is a non-contrast CT abdomen. Then is glomerular hematuria. So they would be like RBC casts present in a patient. There would be cola color urine present. RBC cast was not in the options. Cola color urine was, but then there were like two options, and I had to select one thing. Apart from this, that could be like edema component, because the kidney will fail. Obviously, the edema will not be so severe as you get in nephrotic syndrome. You see, in glomerular hematuria, there is bound to be glomerulonephritis component, so the GFR is affected. So once the GFR is less, renal failure is occurring. So there could be like periorbital edema present. So edema word, like, okay, fine, I'm taking into consideration. Less common as compared to nephrotic, where the patient will all be bloated, but the remaining options make it less likely. So that helps me come to the conclusion for option number A. Then in renal transplant, which is suggestive of a rejection. So serum creatinine is, I would have, even if I've not read this topic, what I'll say is that I will select the highest possible value in this particular case. So elevation of creatinine 10% above the baseline, because when you have a graft coming in the body, no, and there is a possibility that the graft may not be able to achieve the baseline values, like normal creatinine in our body is 0.1 to 1.2. It may never come back to normal after the transplantation. It may still be on the higher side. So it is just that I'm looking for elevation over the baseline. I'm not talking about normal values. I'm talking about elevation over the baseline. So I'll select the highest possible value in this case, which would help me come to the answer to this question as option number A. Then is a brown urine. Okay. Means same only, doctor. I mean, cola color urine, brown urine implies the same. Okay. Trauma patient is having a blood pressure of 80/60, absent breath sounds on one side. That means he's going into tension pneumothorax, and the Glasgow coma scale of the patient is also low. The reason for that is, one reason for like Glasgow coma scale being low is hypotension. So the blood supply to the brain is less. Second possibility can be a head injury in a patient, because the GCS of the patient is 8. So first thing to be done is securing airway. So I have to select between option number A and B in the patient. But after securing airway in the patient, I will give supplemental oxygen, because lung is like only one lung is working, and then we'll treat the chest tube, put in a chest tube so as to evacuate the air, and then giving fluids to the patient would make sense. But giving fluids before putting chest tube would not be advisable, because the fluid will not reach the heart, because SVC and IVC are compressed in this condition. Tension pneumothorax, we call it tension because it is obstructive shock. SVC IVC दब जाता है तो फ्लूइड देने का कोई मतलब नहीं है. पहले चेस्ट ट्यूब डालेंगे, उसके बाद में IV फ्लूइड देंगे. So the answer to this one should be option number A. In case any permutation combinations, yes, Dr. Mishra, one option was only dysuria. So dysuria is a feature that is seen with the urinary tract infection. No, dysuria मतलब वो यूरिन पास करके आया और फिर वो कहता है कि मुझे फिर से जाने को लग रहा है, कि मैं जा रहा हूँ तो बूंद बूंद यूरिन आ रहा है, जैसे अभी हो के आया, कहता है अभी लग रहा है फिर से जाना है. And when he'll go for the second time, then it would be like, that only 2 drops came, and like the person is feeling as if he needs to go again. Okay. This one would be option number A, guys, because first is airway, because GCS of the patient, anybody less than GCS of 8 or less than 8 is comatose. That is why airway. Then is oxygen to be provided. Then is chest tube to help the BP come up, and then subsequently systolic BP of 90. Okay, doc. Okay. Systolic blood pressure of 90/60 in the patient. Okay. Anything else in the options if you want to modify? I mean, if I'm missing something with respect to some chest tube aspect, like he talked about underwater seal in the question, the sequence would be like this only. I mean, give secure trauma case or airway, then is oxygenation. C-spine was not, the C-spine is not involved in this case. Okay, so we are sorted for question number 25. Let's move to 26, which is not included in NADA's criteria. So among the major ones, we have congestive heart failure, and we have diastolic murmur, and we have minor criteria that is going to be like abnormal X-ray, abnormal S2, and abnormal ECG in a patient. But then troponins are like, not a part of congenital heart disease. So I think this was an easy pick. C. Which is not a feature of cystic fibrosis. If you can just check out the options there, meconium ileus is there and nasal polyps can be present. That would be upper respiratory tract involvement in the patient as well. Okay, fine. Diastolic is not given. Fine, guy. Doc, I got it. I mean, hypotension is there. That is the concept behind the question. Doctor, yeah, you can drop me a mail at marvamedicine@gmail.com. I'll be able to look at your query in a much more comfortable fashion. So drop me a mail at marvamedicine@gmail. Okay, insert ICD was only in one option. Uh, okay, okay, got it, got it, got it. Mhm. So putting a chest tube makes that makes it, I think, easier for us to finally arrive at the answer to this question. Let me know a bleeding tendency, biliary atresia, like that. Yes, guys. Or was it biliary cirrhosis? My query is it like biliary cirrhosis or is it biliary atresia? Okay, options are correct. So we'll work out the answer to this question because biliary cirrhosis can be seen in cystic fibrosis, but not biliary atresia ना यार. Biliary atresia तो मतलब एक isolated congenital malformation है. तो बाकी the remaining options will make it obvious. No, pancreas cystic fibrosis होता है ना जिसमें pancreatic juice becomes thick. I mean the main concept is exocrine gland is involved and the pancreatic juice is very thick, so it is not able to come in the GI tract. And if pancreatic juice is not able to come, then amylase will also not be coming appropriately, so osmotic diarrhea, and lipase will not be coming, so there would be steatorrhea. And because lipase is not there, so fat will not be absorbed, and because fat is not absorbed, then fat soluble vitamins can also be affected. So that would help in coming to vitamin K deficiency. ADEK, like there would be bone pain, there would be night blindness, there would be hemolytic anemia, and bleeding spots can develop in the patient. So that explains the bleeding tendency component, and therefore the answer will work out to biliary atresia. My concern was only whether there was mention of biliary cirrhosis, because we get secondary biliary cirrhosis in patients of cystic fibrosis. But atresia, then though it becomes relatively easier. Okay, moving to the next one, which of the following will be a primary stimulus for closure of ductus arteriosus? That would be increase of oxygen tension in the body. Rest of them do not fit the description. Epinephrine, resistance of pulmonary vessels will become lesser, in fact, after birth of the baby, and it is high oxygen tension, which is the trigger in this particular case. Because earlier, it is exposed to lesser oxygen tension. Now the lungs are inflated like two big parachutes, so a lot of oxygen is coming in the body. So high oxygen tension is the reason why this would begin to close. I have explained 27, doctor. Bleeding tendency, the reason being vitamin K deficiency due to fat malabsorption. So I think that makes it easy to comprehend. Okay, 28 is sorted. We move to 29, and I would like you to look at these values of blood pressures and let me know if everything is fine, and then we can analyze this question. Patient presents with blood pressure of 220 by 130, so there was a hypertensive emergency given in the case, or was a hypertensive crisis, and the features of stroke. Did he mention any type of stroke, like ischemic stroke, hemorrhagic stroke, or was it like only stroke, or was it like some features given, like face weakness, arm weakness, like that? Any neurological features? Can I have like some comments with respect to any features of stroke? Like, I mean, that is a very broad statement. So any specific features given in the question? And then are the blood pressure values. Okay, guys. Fine, guys. I think I am getting a couple of inputs. I missed them in the chat maybe, so I'll just wait a couple of seconds. Hypertensive crisis, we need to check BP. Initially, due to sympathomimetic stimulation, the BP can be very highly elevated. But to be sure that it is elevated, I would suggest to wait for 5 minutes and check the BP again in the patient. So checking BP multiple times, like at least 2 times I will check now, because first time I thought because of like neurological illness, because patient is having face weakness, arm weakness, so he is nervous, and that is why sympathomimetic stimulation can contribute to high BP as well. But then once persistently like 2 values are elevated, that tells me that okay, my patient is going into hypertensive crisis. In all cases of crisis, we should avoid sudden lowering of BP because it can trigger development of cerebral ischemia. So far so good. I mean, option number A and option number D makes sense here, in a sense that more than one value should be tested, and rapid reduction of BP should be avoided because of the risk of cerebral ischemia in a patient. Uh, Okay, only BP was given and intracranial hemorrhage. Okay, so there are two values which are given, 140 and 160. So can you comment regarding it? I'll one focus on what options I have got. Reduce systolic BP to less than 140 in spontaneous intracranial hemorrhage. Makes sense because leading cause of intracranial hemorrhage is hypertensive crisis. So I mean, in hypertensive crisis, if the BP remains elevated, then the chances of bleeding and increase of bleeding will be substantially increased. But when it comes to ischemic stroke, if I have to do a acute reperfusion therapy, then the cutoff that is mentioned is like 185 by 110 millimeter of mercury. Here it is saying like less than 160. So it is less than 180 by 110 for if the patient is a candidate for thrombolysis. So based on this, option number C is the wrong statement. He says which of the following should not be done. He says bring the BP to less than 185 by 110 and not to less than 160. I am open to any discussion with respect to any values or modifications in the blood pressure values that you want to make in the case. Because if he gives only elevated BP and then says stroke, he has tested your knowledge of both hemorrhagic as well as ischemic stroke. In ischemic stroke, the BP should be lowered to less than 185 by 110, and in hemorrhagic stroke, it should be lowered to less than 140. And I'll give you references for the same as well. You can check out in the main videos as well. But today I have is the textbook reference. So this is what the book says, that in systolic BP should be lowered to less than 140 in patients with spontaneous intracranial hemorrhage. The reason for this being hypertensive crisis. And in case the patient is the candidate for reperfusion therapy, that means thrombolysis, then the goal of the BP is like this has been like discussed a lot of times. 185 by 110 is like the threshold, and every time the BP is elevated, we should try to lower the BP. If you can't lower the BP, do a mechanical thrombectomy in this patient. So based on these values here, the correct answer for this one will work out to be option number C. I would like to achieve a target of this one to be safe in the zone. And why this target has been established is the AASA guidelines. I mean, he says that anything lower would contribute to cerebral ischemia also, because the BP is already established at a high set point. So lowering of BP below this level, I mean, the query of most people would be, sir, why not less than 160? दिक्कत क्या है, मतलब 180 बोल रहे हो, 160 कर दिया तो क्या है? तो बोलता है कि that 20-point decrease in systolic blood pressure will decrease the mean arterial pressure, and that will compromise the cerebral perfusion. You know, एक formula होता है, cerebral perfusion pressure is a difference of mean arterial pressure minus the intracranial pressure. And in case the mean arterial pressure in the patient is like super elevated, if intracranial pressure is elevated, then the CPP becomes lesser. So to counterbalance this, I'll repeat that again. Brain में pressure बढ़ रहा है तो CPP कम हो जाएगा, तो उसको counterbalance करने के लिए MAP is required. So why like keeping that threshold is recommended is because otherwise like the CPP will become substantially low. So these are inputs from my side at this particular point of time, guys. I can say stay focused, keep hammering, and this is like worth the sacrifice. So in case you have any options or any other questions, then let me know. Otherwise, thanks Dr. Mishra for the input for the same options in this particular case. So we'll keep on collecting these questions, modifying these options, refine them, and then present to you in the app where you can practice these questions. Any queries from your side with respect to this paper, or any queries with respect to any question, are most welcome. It's an open house at the moment, though I try to take up questions in the middle also, because otherwise, you know, the chat is so long that finding those questions becomes very difficult in the end. Mechanism of heat loss in a desert, doctor. One would be evaporation of water from the body, no? One primary would be evaporation of water from the body. मुझे नहीं पता रिजल्ट कब आएगा भाई, सरकारी चीजें तो आई कैन नॉट आंसर, अपने बस की नहीं है सरकारी सिस्टम को समझना. Okay, guys, so thank you so much for being with me. It's been a pleasure, honor to handle the deep sea diving. And Hope to see you sometime in future. Yep. The answer is C to this one. Fine, guys. Thank you so much for joining in this discussion. अच्छा क्वेश्चन था मेथड ऑफ हीट लॉस इन अ डेजर्ट टेम्परेचर वाज 40 डिग्री सेल्सियस. डॉक्टर मिश्रा, आप मारवा मेडिसिन एट जीमेल पे एक बार अगर ड्रॉप कर दोगे मेल, तो दैट वुड रियली बी नाइस. आई मीन थोड़ा मेरे लिए इजी हो जाएगा ना ऑप्शंस को सिलेक्ट करना. इट वुड बी, I mean, I think it's clearly visible only. marvamedicine@gmail.com. Okay, guys. Thank you so much for joining with me, and I'll catch up with you later. Scuba diver. Okay, I saw that that was discussed hemodilution, na? Because scuba diving decompression sickness will not contribute to. Question was like what will not be seen. So I skipped that because I think it has already been discussed. It would be hemodilution, which would not be seen in the patient. Okay, guys. Bye bye. Thank you so much.